Hello, everyone. My name is Simaza, and today here we're with Professor Dr. Cem İyibozkurt. He's specialized in gynecology and obstetrics. And today's topic is gynecological cancers. We're going to talk about risks, diagnosis, and modern treatment approaches. First, I'm going to start with general questions. The first question is, what are gynecological cancers and which types are most common?
Hello, everyone. This is Dr. Cem İyibozkurt. I'm a gynecological oncologist, and I've been in this university and hospital for almost 8 years. I hope you'll enjoy the information we give, and you may provide questions after we discuss the questions. Mainly, we have the most important gynecologic cancers are, if we start from the abdomen, the tubal and ovarian cancers are very important. Those are the most lethal carcinomas that we see in women. And then we have endometrial cancers, which are almost the most common, especially in European and American populations. Because we have some overweight people, especially in Turkey too, we have a lot of endometrial cancer cases. It is the most common gynecologic cancer in our country too. And then we can have some sarcomas, which are like myomas, but malignant myomas of the uterus as cancers. And then we have this cervical cancers, which are probably more common in the Balkan states, in Europe, and the Middle Asia. It's also seen there more frequently. And then we have the vulvar and vaginal cancers. Those are also seen, but they are not very common. Especially vulvar cancers are seen mostly at very late ages of women, like 60s, 70s. So, we don't see them very often. So these are the gynecologic cancers that we mostly see. There are some other gynecologic cancers that we see after pregnancies, like molars, tissues, hidatidiform mole that we say, and gestational trophoblastic diseases. Those are the cancers that we see.
Okay, doctor. Now, my second question is, what's the prevalence of these cancer types and what are the main risk factors?
If we start from the most common endometrial cancers, as I've already told you, endometrial cancers especially arise during the ages of perimenopausal years. So it's like 50 years of age. The people who have irregular menstruations, the endometrial lining thickens and may start hyperplasia and cancerous tissues there. So when people have abnormal bleeding, we usually call for endometrial samplings. For endometrial cancer, the main risk factors being overweight. And if you have irregular bleedings, especially during your reproductive years, like if you have PCOC and you don't ovulate regularly, these things increase your endometrial thickness and may lead into cancer in the upcoming years. And the fat tissue also secretes estrogens, so they also cause endometrial hyperplasias and cancer. For the cervical cancer, the prevalence is not very much. It depends on the degree of vaccination and, of course, the degree of that you do these pap smears and HPV tests. If a woman is screened regularly, it's almost improbable for her to get some form of cervical cancer because you can recognize the pre-invasive, preclinical cancers, so they don't develop into cancers and they are treated. The main risk is, of course, having HPV. Almost all of the cervical cancers, especially also vaginal and some of the vulvar cancers, are HPV related. So if you're vaccinated, then probably you'll be effectively prevented from getting cervical cancer in the future. For the tubal and ovarian cancer, we know that almost 30 to 40% of the cases are related genetically. The lifetime risk of having some form of ovarian or tubal cancer is like 1.5% in a lifetime. So it's not very frequent. But if you have relatives that have breast cancer or tubal ovarian cancer in the relatives, that risk increases. Some of these cancers, as we know, and probably as you also know, are like BRCA or some other form of genetic related diseases. If a person is carrying like a BRCA1 mutation, this 1.5% risk rises up almost to 50%, 40 to 50%. So then we always do something for these patients.
And my third question is, what are the early signs of gynecological cancers and how can women recognize them?
Let's start from the worst. With the tubal and ovarian cancers, usually these things develop in the abdominal cavity. So when they grow, people usually don't realize these things. So they don't cause any symptoms. So they should have some form of ultrasound examination in order to understand these pathologies. Once they develop, the ovarian cancer usually causes a lot of fluid also. So if some people, some women, let's say, have a hard time losing weight, that might be a factor that draws these women into examinations. They cannot lose weight, or they have some bloating, some gastrointestinal symptoms. So they apply for gastroenterologists and internal medicine doctors. They send us these patients. With the cervical cancer, there should be, of course, smear and HPV screenings for the patients who does not have any symptoms, but some bleeding after sexual intercourse or some intermenstrual bleedings or lots of bleeding and pain might be some symptoms of this disease, but this doesn't necessarily mean that these things are only caused by cervical cancer. A lot of benign things can also cause these things. So we always advise women to go to their gynecologist once in a year. For the endometrial cancer, usually these result in intermenstrual or postmenopausal bleedings. So women tend to come to the outpatient clinics for this kind of bleeding. And most of the endometrial cancers are diagnosed in early stages and highly curable.
So now we're going to talk about the diagnosis and the treatment process. What methods are used in the diagnosis of gynecological cancers?
We always use examination ultrasound for almost all of these cancers. As I've already mentioned, for the cervical cancer, if you see it, because it can be examined, you can see these cervix. If you see some form of tissue there, you can always take a biopsy, so it's easy to diagnose. For the endometrial cancer, these intermenstrual or abnormal bleedings almost always necessitates a form of biopsy. It can be some form of a curettage or a pipelle biopsy, which can be done in outpatient setting. For the ovarian and tubal cancer, sometimes we do some CTs and MRIs to see the extent of the disease, and we also do tumor markers. when these are added up carefully and examined carefully, sometimes we conclude that this patient also has some form of tubal and ovarian cancer. We not always do a biopsy for these patients. We treat them by operations. If these patients need to undergo some form of chemotherapy first, then we opt for biopsies.
And here we have a question related to the HPV vaccine, which you already mentioned, doctor. How effective is the HPV vaccine in preventing gynecological cancers, and who should receive it?
We have some good news about this HPV vaccine. HPV vaccine is almost advised for almost all women, especially before starting some form of sexual activity. Mostly it's done in girls between 9 to 15 years. The posology changes according to the vaccine company and some other states, but this is the most effective time to do it. For catch-up vaccination, women who are less than 25 years of age may have it. And in most of the European countries, women between 25 to 45 also can have this vaccine. The effectivity is very high. It almost prevents all of the HPV-related condylomas, those small things that appear on the external genitalia of a woman. It's almost effective for all of those cases. And with the current vaccine, which has 9 types of HPV inside, the latest one, the effectivity of preventing cervical cancer cases approaches more than 90%. So it leaves a small amount of cervical cancer patients not covered, let's say. So the World Health Organization is trying to eradicate the cervical cancer. So they put up some aim like that. So vaccine is an important part of this program.
What roles do surgery, chemotherapy, and radiotherapy play in treatment?
Yeah, let's start with the cervical cancer first. If these are early stages of cervical cancer, surgery might be enough. You can just treat the patient. In some women, cervical cancer may be seen in a reproductive age. So if the tumor is small, you can go for fertility sparing surgery techniques. And then mostly if the cervical cancer is a bit advanced, or the tumor is a bit big, or extends outside the uterus, then we go for chemoradiotherapy. Chemoradiotherapy is almost as effective as surgery for cervical cancer cases. For endometrial cancer, usually the mainstay of therapy is surgery. Surgery usually cures the disease. Sometimes we use radiotherapy as an adjunct if it has spread to other like lymph nodes. Then chemotherapy then also be given. But if it stays if the tumor is in the uterus and it just invaded the myometrium a bit, then radiotherapy is only enough as an adjuvant therapy. But most of the endometrial cancer cases, surgery is usually enough. And for the tubal and ovarian cancer patients, those are almost always treated by a combination of surgery and chemotherapy. For most of the epithelial ovarian cancer patients, this is the rule. It depends. The succession changes. Sometimes you start by surgery, sometimes you start by chemotherapy and then do surgery and continue with chemotherapy again, or you start with surgery and do the chemotherapy like for 6 cycles, then it's treated. Usually we don't use radiotherapy for most of the ovarian cancer patients.
And what are the advantages of robotic surgery and minimally invasive techniques in treatment?
We use a lot of robotic and minimally invasive techniques here because with minimal invasive surgery like laparoscopy and robotic assisted laparoscopy, let's say, you can be discharged as early as a day. So the recovery periods are very reduced, and the incisional sites are very small. Like you use 5 millimeter trocar sites for laparoscopy and 8 millimeter trocar sites for robotic surgery. So especially if it's a woman who's obese, or let's say has diabetes, for example, the smaller the incision, the smaller the complications. If it's possible to do by laparoscopically or robotically, we go for those choices of treatment. The robotic surgery also has the option of showing us a 3D visualization, and you can use the robotic arms like 360 almost degrees of rotation, like a wrist. So it's a very versatile type of surgery.
And now we're going to talk about prevention and lifestyle. What lifestyle changes can help women reduce the risk of gynecological cancers?
I mean, for the ovarian and tubal cancers, it's not usually lifestyle related, but if they just, I mean, I would advise for every woman who's watching us to go over their family history of cancer. If they have family history of breast, tubal, ovarian, pancreatic, prostate cancer, they should advise, they should go to their doctors and get some info about these things, because some of these, as I've told you, are genetically related. So if you know that, and we have some patients, but we know that they carry these genes that lead to ovarian and tubal cancers, you have to follow them up. Sometimes we do risk-reducing surgeries, like take the tubes and ovaries out after they have completed their childbirth. These are options that really decreases their chances of getting an ovarian cancer. With the endometrial cancer, keeping your diet and maintaining your weight is very important, because endometrial cancer is mostly seen in countries where they have overweight people. So it's related to estrogen, as I've told you. So if you keep up with your weight, if you do your exercise, and if you continually monitor your cycle, it's highly likely that you won't be getting any endometrial cancer due to those reasons. With the lifestyle changes of cervical cancer, if you come to this, this is it's like a sexually transmitted disease, cervical cancer. You get HPV over someone, and then you can develop this type of cancer. I mean, I don't say that you should change your sexual practices, but you should keep up with your regular yearly follow-ups.
And the next question is related to the answer that you just did, doctor, is how important are regular gynecological checkups, and how often should they be done?
Gynecological checkups are important because most of the problems, I mean, it doesn't necessarily have to be some form of cancer. It can be some due to benign lesions, myoma, cysts. They can be easily identified by ultrasound. And if you have some form of pain or some other symptom, it's wise to go to a gynecologist, because cysts may grow up to sizes like 10 to 15 centimeters without giving any symptoms, because the pelvis usually bears a baby's head, for example. It's like 10 centimeters diameter. So people don't understand it, even if they have a cyst. So we advise yearly control for women, and this could be increased if they have special like genetic problems, of course.
You mentioned how family history is important. If there is a family history of cancer, are genetic tests such as BRCA testing recommended?
This is certainly done. I mean, if a family has a person who has ovarian cancer, in the world, almost all parts of the world, for that person, a genetic testing is necessary. If that person carries some form of a mutation that causes ovarian or tubal cancers, then the relatives of this person should be evaluated just for that type of mutation afterwards, so that they would know the risk of getting cancer in the future or not. So if you have a family history of, for example, or let's say a woman who's less than 50 years of age and has some form of breast cancer, it's also an indication for doing some form of genetic testing. These things may reveal if you have some form of risk for having a genetically associated cancer. This doesn't necessarily have to be a gynecologic cancer. This could be other types of cancers also.
And innovations and future perspectives. What recent advancements have been made in the treatment of gynecological cancers?
With gynecological cancers, especially in ovarian cancer, there are like more immunotherapies and targeted therapies that are getting more effective rather than conventional chemotherapies. Those are like used. We also use here like HIPEC, which is which you heat the chemotherapeutic agents and do it during the surgery. It's also can effectively reduce the timing of a relapse. And for the cervical cancer, as I've told you, HPV vaccine is a very big breakthrough. For the endometrial cancer, it's the staging of endometrial cancer is changed. It's one of the first cancers that has included molecular and genetic typing into the staging process. So now we can look up for some genetic modifications in the type of endometrial cancer and stage the patient accordingly and decide on the adjuvant therapies. These are mostly related to us, of course.
And my last question is, what promising developments are on the horizon for future treatment options?
I think the upcoming thing about future treatment options is the development of more effective immunotherapies and chemotherapeutic agents for ovarian cancer. Now we always do surgery for these patients. Maybe in the future, some form of immunotherapy will be so effective that we don't need to do any surgery for these patients. Usually, even if the disease is disseminated, we start with some form of immunochemotherapy, and then we do the surgery for these patients to reduce the risk of relapse. So for the near horizon, let's say, that's the promising development, I would say. For the other things, nothing has changed much over the recent years.
Thank you so much, Doctor, for your valuable insights. Thank you for watching, and until then, stay tuned and stay healthy.
Bye.